Hey everyone, Dr. Emma Petshow here. I'm here today to go over your second case for gastro tutorial, and this case is all about recurrent upper abdominal pain. As all of you know at this point, you have made it through the case, so you are aware that our 42-year-old female who has recurrent upper abdominal pain has this pain due to a gallbladder condition. But we will get to how we differentiate and get to that gallbladder condition and the steps and resources we took to get there, especially some resources that I take in my personal practice to help me differentiate between a case like this. So first, let's just review some of the salient points from this case. So our patient has pain in her upper abdomen, in the epigastrum and right upper quadrant that waxes and wanes. The pain's been getting worse, but it's been going on for a long time, so it's chronic. She has noticed it worsens with some fatty, greasy foods. When we go down to physical exam, we can see her vital signs are relatively regular. She's afebrile. Her abdominal exam does have some tenderness in the epigastric region in the right upper quadrant, and she has a positive Murphy's sign. So when I have a patient that comes to my practice with abdominal pain, I like to really take a step back and do a broad approach to make sure that I'm not early closing on a diagnosis. What that means is choosing a diagnosis before I've considered all my other options. So when we think about abdominal pain, a great way to differentiate different potential causes or etiologies is to look at location of pain and quality of pain and some other factors as well. This up-to-date article, Evaluation of the Adult with Abdominal Pain, does a really good job of giving you a broad picture of how to approach a case like this. So here we know our patient has epigastric and right upper quadrant pain. So we're thinking that potentially based on these areas, we could be dealing with the liver or the gallbladder because that is in the right upper quadrant. Although we can't forget about the pancreas, the stomach, the spleen, the diaphragm, and that lower esophageal sphincter esophagus, as well as other potential causes that can have pain radiation to the right upper quadrant. When we're thinking about working up the patient though, next steps, we can consider things like a complete blood count with differential to look at things like a white blood cell count, or look for anemia or potentially bleeding, make sure there's no signs of infection. Can consider a comprehensive metabolic panel that looks at electrolytes, kidney function, liver function, bilirubin, a measurement of gallbladder function, lipase or amylase, looking at the pancreas. And then we want to also consider imaging, but we're going to come to imaging here in a second. I also want to have you recognize that this up-to-date article has some really great tables and charts. This one is just for the right upper quadrant abdominal pain that goes through some different etiologies, some clinical features that you might see, and then some other things to consider. So with our patient, we can think about maybe a gallbladder cause. So we have biliary colic, acute cholecystitis, acute cholangitis, all these different terms, which gallbladder disease can get confusing with its terminology, and we'll get to that. But this can be a nice chart that can tuck away in your black book or clinical book and can help you narrow in on a diagnosis and next steps. So when we think about imaging, we know that our patient, we did order an ultrasound and we got those results, but how did we choose what imaging to order? That's where I really like to use the American College of Radiology, the ACR, the Appropriateness Criteria website, which I have pulled up here. And again, you'll get access to these links next week once everyone has had time to complete the case. You'll have access to these resources. When we look at this appropriateness criteria, the great thing is you can look up things based off of organ system and symptoms or condition area. So for our patient, we can scroll down to the region of right upper quadrant pain, and then we can see that there's these evidence tables. And these evidence tables give us different imaging options for evaluation of the patient's symptoms, appropriateness criteria based off of evidence, and relative radiation level. So this can be a great teaching tool when it comes to encouraging your patients to get a certain type of imaging over another. So you can see here when we look at this variant 1, right upper quadrant abdominal pain, suspected biliary or gallbladder disease, the initial imaging, an ultrasound of the abdomen is what's usually appropriate. So that's our highest recommendation, which is what we did for our patient. Now, when we got this ultrasound of the abdomen back, we saw that it showed cholelithiasis with no signs of acute cholecystitis. So what does that mean? So let's get into, okay, we know now it's gallbladder disease. We know that that's what we're leaning into as a diagnosis, but how do we know what type of gallbladder disease or what we should call this gallbladder disease? That's when this up-to-date article that is overview of gallstone disease in adults becomes really handy, because there's this terminology section that lists out different things for us to consider. First, we have cholelithiasis or cholelithiasis. Cholelithiasis refers to the presence of gallstones in the gallbladder, but the presence of stones in the gallbladder, the incidental finding of stones on imaging, is not considered disease unless if they are symptomatic. Okay, so we do know that our patient has cholelithiasis, so they do have stones in the bladder, but that wouldn't necessarily equal gallbladder disease if she was asymptomatic. Now, our patient, she has symptoms. We'll have to move down to the next step. Gallstone disease is considered gallstones that are symptom causing, which our patient has at this point. So then we have uncomplicated versus complicated gallstone disease. So the differentiating factor is really uncomplicated gallbladder disease refers to biliary colic, so that waxing and waning pain in the upper right quadrant, in the absence of gallstone-related complications. This diagnosis fits our patient's picture. So we would call this patient uncomplicated gallstone disease. They have cholelithiasis with biliary colic. Complicated gallstone disease refers to gallstone-related complications, which could include acute cholecystitis, cholangitis, gallstone pancreatitis, gallstone ileus, amongst other complications. So our patient, we have decided that they have symptomatic gallstones. They have biliary colic. And when we think about biliary colic, it's this intense, dull discomfort in that right upper quadrant or epigastrum region. It matches our patient's symptom picture. So when we think about that, there are some other symptoms here in this article, and then we think about complications that can arise. And that's where we have to have those clinical discussions with our patient, because this patient that we have in front of us, she has uncomplicated gallbladder disease right now. That does not mean it can't lead to complications later on. I've had 2 patients in my office in the past 2 years who have had uncomplicated gallbladder disease that have then progressed to complicated gallbladder disease over the course of time, one with relatively no risk factors and the other with many risk factors. The one patient that had no risk factors, she was very adamant about not wanting to have a cholecystectomy, not wanting to have her gallbladder removed, but her symptoms progressed to the point where she did develop an acute cholecystitis. And because we had already had these conversations, we had already referred her to general surgery to have a consult of what symptoms do I watch for and what do I do if I get to that point, and what's our action plan if I need to have a gallbladder removal procedure done, a cholecystectomy. So when that did occur, she was prepared, we had a plan, and we were able to execute the plan successfully. My other patient, we had not had those conversations because we didn't know that he had any gallstones or even uncomplicated gallbladder disease. At the time, he was having symptoms that weren't necessarily consistent with gallbladder symptoms or gallstone symptoms. He was asymptomatic and then developed an episode of pancreatitis. It turns out it was gallstone pancreatitis. And so the gallstones were an incidental finding upon his hospitalization. That patient ended up not getting his gallbladder removed, but we did have to create then the action plan after the fact to make sure that we were setting him up for success or failure. Those conversations can be challenging with patients because it involves removing an organ, and that is a very intimate thing, is losing something from yourself. And so having those conversations is really important early on, because whether or not a patient keeps their gallbladder or not in the long run, they can still have a very full and fulfilling life. Now back to our patient, our 42-year-old female. She has uncomplicated disease, so she is not a candidate for surgery at this time, but still having those conversations about what to watch for, what symptoms to watch for, and what's her expected prognosis would be important. We can see here under this natural history and disease course, it shows that approximately 15 to 25% of patients that have asymptomatic gallstones will become symptomatic over 10 to 15 years. So that means that 3/4 of people who have asymptomatic gallstones aren't going to ever become symptomatic over that 10-year time frame. So it's not necessarily very common, but it's just something to keep in mind. Feel free to come with your questions to our debrief this next week on Thursday evening. I'm happy to talk about how those conversations went with my patients further. I had a very interesting case with a complication after a cholecystectomy, the differences between the presentation of acute cholecystitis versus pancreatitis from gallstones. There's lots of stuff, lots of great stuff to unpack here. But again, big points to remember with our patient: when you have an acute abdominal pain or any abdominal pain case, keep your differential broad, narrow down based off of location, and make sure that you're ruling out acute or emergent symptoms as you go with your exam and your history. Choose your imaging based off of appropriateness criteria. And lastly, make sure you know your terminology and correctly diagnose your patient.